please help spread the message of Frequency Specific Microcurrent by clicking on the like button. You can subscribe to us on YouTube or any podcast app. If you have any questions, please leave them in the comments. You can find the podcast transcription at frequencyspecific.com, as well as more information about Frequency Specific Microcurrent.
Eduardo and I worked on that person in Rome.
Yes.
And the second day after we got him out of pain and did all the things, I took his knees up towards his chest and they stopped at 90 degrees. And then I explained to the class, okay, that means his dura is stuck, and watch what happens when we do scarring in the dura. I worked on his pelvis and external rotation and scarring in the dura, and then looked up at his head. And as I bent his knee, his head tipped back, but then I looked at his face. You know how cranial bones move?
Yes.
When the anatomists say they don't,
Yeah.
and the craniosacral therapists say they do.
Yeah.
It was like, Eduardo, can you check his cranials? Because he's a cranial osteopath.
Yeah.
And he went, oh, yeah. So he did the cranial dural, and we had the patient do a Valsalva to increase intracranial pressure and stretch the cranial dura, while Eduardo worked on the suboccipital foramen magnum connection of the dura and the brain and the spinal cord. And then at the end of it, his face was a different shape. His eyes were clear, and he walked. We had to teach him to walk again because now his dura was not stuck to his tailbone and his head.
Right.
And Eduardo said, of course I'm coming to the advanced. And I said, how would you like to do an advanced hour-long presentation on the dura, what it does, why we treat it,
Yeah.
and then how we treat it?
Yeah.
And within 48 hours, Eduardo had done a literature search on the dura and all of the things it does that I didn't even know it did.
Yeah.
And now, on top of everything else at the advanced, I'm like totally geeked out for that 1 hour-long presentation, in addition to everybody else that's coming.
Yeah. Let's unpack that, because
You end up saying that a lot.
because I feel like you drop these like packages, these verbal packages, and then you're just like, here you go. And I'm like, no, you're sitting here and you're watching me unpack this.
Okay.
Because if I'm trying to absorb it in real time, then there's other people that are trying to absorb it. And I think you take for granted your cranium that is jam-packed full of knowledge that you're just like, oh yeah, it's just there. And we're all trying to
Saying what, huh? Yeah.
Yeah.
Sorry.
And remember, we've got lay people listening. So the dura is almost like the periosteum sort of love affair that I had with FSM, because I knew of the dura, but I didn't care about the dura so much because I couldn't touch the dura and I couldn't palpate the dura and I can't contract the dura and I can't teach the dura to do anything, but I had respect that it was there, just like the periosteum. However,
Once you can treat it,
and it was crazy because the dura frequencies were not in the core initially. They were, and it was an advanced frequency. However, at one of the first core I was at, we were doing something with like spinal flexion, and somebody was like, oh, that's just the dura. And I'm like, what do you mean that's just the dura and you're like not jumping out of your sneakers right now? Like, we can affect this. And I was the person on the table flexing forward, and I felt that was the first time I felt the effects of FSM, because I was that one in that bell curve when we're holding hands. I really want to feel something, but I don't. And I experienced smush as a practitioner. I could feel it, but when it was on me, it was a bit of a,
yeah.
yeah. And I wanted to.
Yeah.
when the Dura frequency was applied to me, all I can say was, in a word, it was like freedom. My spine could flex in a way that was effortless.
And your hips could flex.
Everything. My head could drop, because that's one of the things too, when we're looking at spinal flexion for people. And flexion, if you have a yucky disc, flexion is usually yucky. If you have icky facets, extension is icky. But there's also the Dura that is a component in all of that. And when the Dura is tight, and I know the cranial people will have a lot more to say about this than me, my knowledge is very rudimentary. You'll see the sacrum and the head they don't want to move. So like when people are dropping forward into flexion, a lot of times with the Dura, people will go into cervical extension, not even knowing why, because the Dura goes from the head all the way down to the tailbone.
It attaches at the foramen magnum. It's got a sturdy attachment at the foramen magnum, and then right behind your eyeballs, right behind the bridge of your nose, and then under the base of your skull.
Yes.
And it is basically in 4 parts around the brain, and then all the way down the spine, attaching with little ligaments that attach to each nerve root. And then it's just inboard of the SI joints along the sacrum, and it attaches to the tailbone. So the patient's experience is, I can't bring my knee to my chest. And everybody says, oh, whatever muscle is tight.
They think glutes right away.
Yeah, or psoas or hamstrings or whatever, glutes. And the fact of the matter is that in order to bring your knee to your chest, you have to take your sacrum and your pelvis and take it with you towards your chest.
Yeah.
If your dura is stuck, tight, fibrosed, whatever, your cerebellum is not going to let you flex your pelvis, and your knee won't go to your chest because it'll pull on the dura. So you press the patient's knee and it stops hard at 90 degrees. And if you push it a little farther and you pay attention, the patient's head tips back about 5 degrees. You push and they go like that. Push, they go like that. It's a dura, because it's the only thing that connects the sacrum to the base of the skull.
Where do you think fascia gets involved in that equation?
With all apologies, abject apologies to John Sharkey, the fascia is a passenger on the bus. The fascia is innervated. And the fascia, I think, my experience of the fascia is that it responds to underlying pathologies.
Yeah, I'd agree with you.
Because the fascia is innervated.
Mhm.
Where do the nerves come from? The brain.
Mhm.
And what controls the nerves? The cerebellum. Is the cerebellum going to let vital tissue be injured by stretching? No. So if you release the dura, all of a sudden the fascia responds instantly and becomes looser. The fascia is never restricted experience. We treat the fascia when we do the supine cervical practicum, treat all the underlying, the facets, the discs, the ligaments, and at the very end, for the people that think the fascia does something, we do hardening in the fascia and scarring in the fascia, and 100% of the time, nothing happens. We do increased secretions in the fascia,
Mm.
and the neck gets smushy, which is confusing to me, but increasing secretions in the fascia makes everything soft. I think underlying causation. And with the knees and the neck, it's always the dura. And Eduardo sent me all these articles that I speed read about what the dura is actually, the dura, the pia, and the arachnoid. And they're all together and forming the meninges.
Yeah.
They, especially the arachnoid, drains, recirculates the spinal fluid. And if there's scarring in the dura, adhesions in the dura, gunk in the arachnoid, the lymphatics or glymphatics in the brain, the spinal cord, you don't get good circulation of spinal fluid and detoxification in the brain, the spine, the spinal fluid, and all of the things. And I didn't know that a week and a half ago until Eduardo sent me the papers, and now it's, oh, goody.
So my brain is about to explode in the back of my office right now, because this might make sense why congestion in the dura works.
Yes. And treating the arachnoid, which I never make a big
No.
deal of,
I know.
because I always treat the dura because it includes everything.
Yeah.
But arachnoiditis is an infection and inflammation and scarring in the arachnoid that's caused by usually infection. And that's something we can treat. Nobody else can treat it. And for us, it's just scarring in the arachnoid. It's not that hard.
Say that out loud again for the
I
people.
do. And there's no lightning or anything. I don't get it.
It's a sunny day.
Yeah.
I was just thinking about something as we were talking about the fascia versus the dura, because I do have a newfound respect for fascia. I was not a fascia trained person. Fascia was what we cut away to get at the good stuff with our anatomy labs. Very biomechanically trained. I believe in levers. I believe in fulcrums. I believe in tendon length and insertion. That is my belief system. However, I am open to learning, and I do like the fascial principles. We're learning a lot more about fascia's innervation, its ability to become tensile, explains a lot. And how you mentioned the fascia not being the culprit. Yes, we treat it, but I remember being at a hockey workshop years ago, probably pushing 20 years ago. And one of my favorite people were presenting, and they were talking about the adductor muscles. And because it was a hockey workshop, it was all about hockey players and chronic groin pulls and strains. And we were breaking down the anatomy, and they had brought up gracilis. And gracilis is this really flat, weird, thin adductor. And one of the doctors was saying, now gracilis is one of the biggest jerks in the whole upper leg. And I'm like, yeah, why is it a jerk? Remind me, because I don't like it, but I don't know why I don't like it. And
Well, it's such a little muscle.
It's such a little muscle. So he said it will never cause the problem, but it will hold the problem. And I've never forgotten that voice. And I think of the fascia almost as the same way. So the fascia is never causing the problem, just the muscle is never causing the problem. And I know that's hard for manual therapists and PTs and trainers, because that's all we think is that's where our problem is being caused from. But if you can just table that thought for the side and think, what is this reacting to? I think
until you have a way of treating the underlying cause, you think the muscle is the problem because the muscle is what you can feel.
right.
And I started out as a fashionista.
Right.
I started out as a myofascial therapist doing manual trigger point work in 1989, 90. I was still in school and did ischemic compression. And that's the way I taught and treated with FSM For probably 7 years, we treated the muscle.
Yeah.
And then I found out that if we treated the facets and the discs, so the current supine cervical practicum evolved over 8 years.
Yeah.
And November 1st, I have a chapter due for the update of the 3rd edition of the Trigger Point Manual. And I talked to David Simon's editor, his daughter, and I explained we treat the underlying cause. And she looked at me like I had 3 heads, and she said, you have to publish this someplace. You can put it in the Trigger Point Manual, but you have to write it up and put it in the journal Hypothesis and get it out there, because nobody else thinks this way, because nobody else has a way of treating the underlying pathology. And so that's on my to-do list.
Don't you think, I really have been thinking about this a lot since Dr. Musnick was on recently. When you were gone, he was my guest, and we were talking a lot about autoimmune conditions. And to not get, there are so many takeaways that he had, but one of them was all the underlying conditions. Why is this expressing itself right now? Who cares that you have an autoimmune disease? Why is this showing up right now? And I remember just wanting to stop him at that moment and be like, did everybody just listen to that? And could everybody, it doesn't matter if it's autoimmune or what segment of medicine, but just everything, if we could just pause for a second with the assessment, or look at the assessment or your exam, or however your practice model works, and then just say, yes, their pelvis is this and their facets are this and they're showing up like this, but why? And then that assessment takes you to it. And that's why your first meetings with people are hours long and not minutes long, because
you have to completely reverse the way they look at the world. In my world, autoimmune conditions, there is no way to have an autoimmune disease if your vagus nerve is working.
yeah,
The start is always what turned the vagus down: infection, stress, or trauma.
yeah,
And you go back, and within 1 to 3 months prior to the onset of the first autoimmune flare-up, there is infection, stress, or trauma. That's never not there.
we talked.
And I wouldn't have come to that unless we had the ability to turn the vagus on or up, turn it up. And in order to turn it up, you have to use the frequencies for what turned it down.
Yeah,
So I got this leaky gut, autoimmune, whatever. And in November, what happened in June? I got COVID in September, or I got vaccinated for COVID in September. And vaccinations are artificial infections, which are useful if you do that sort of thing. So they're artificial infections, so your immune system gets alerted to the presence of this virus and detects it. So whether it's an actual infection or an artificial infection, stress and trauma, and then you have to treat the downstream stuff, the joint inflammation or the scleroderma or the asthma or the whatever, rheumatoid arthritis. You still have to deal with the tissue injury that's created by the immune system deciding that your joint capsule belongs to somebody else. But in order to turn off the autoimmune condition, you have to fix the leaky gut and you have to turn the vagus on. And unless you have a tool that lets you do that, you'd never figure it out.
no. Has your stance on vagal tone or who gets to turn their vagus up changed at all? I remember when we first started talking, this was probably a couple of years ago, there would be instances where you would say maybe in that, like your police officers, or there would be a couple different demographics where you'd say maybe we don't want to turn or mess with their or manipulate or address their vagus nerve right now.
If somebody has an active infection,
Yeah.
then you want the vagus
Yes.
quiet.
Yes.
And the fact of the matter is that I had a little reality check. If we use our protocol to turn the vagus up,
Mhm.
and the patient has an active infection, the midbrain will turn the vagus down faster and stronger than we can turn it up. So I'm not quite so worried about it as I used to be.
Yeah.
Football players, there's data, and I'm sure for hockey players too, but the data I know about is football players. At the end of a 3-hour game, they have leaky gut. The stress levels are so high, their cortisol goes so high that the gut leaks by the end of the game. So what do you do with a football player? He's got partial thickness tendon tears, he's got bruises, he's got whatever, injuries. So there is stress, there's trauma. I would still, for a football player, treat that night leaky gut and turn on the vagus.
Mhm.
Now, if the body needs inflammation, it'll turn the vagus back down. But it won't hurt to have it turned up for a couple of hours just to give everybody a rest.
Yes.
Just,
Yes.
yeah,
Someone knit my Vegas a sweater and give it some ease and give
just
everybody a bit of a rest.
just exhale just for a couple hours.
Yeah.
And then inflammation, I don't even treat, remember 40 and 116?
Yeah.
We have the mouse research, and that's really good data.
Yeah.
I hardly treat that on myself anymore, and
Yeah.
even on patients, because if you turn the vagus on, I let the vagus decide how much inflammation I need.
I do love that idea a lot. And I do hear your voice saying that to me. And I love that voice. It says a lot of helpful things to me. But that I do trust that. And as everybody who has listened to me talk in the sports courses about using heat, the doctor that coined the term rest, ice, compression, elevation, has come out to say, I was wrong, shouldn't be icing so much, because we are inhibiting that inflammatory response that can be very helpful. So yes, inflammation can get out of control, but we do need some inflammation there. That's where healing takes place. So I hate it and we talk about inflammation is like this hot word. If you just do hashtag inflammation on any social media, like everything pops up. I'll have people that are like, oh, I'm just so inflamed, athletes, I'm so inflamed all the time. What does that mean to you? We need
That's
it.
the question.
Yeah. Or how much does this inflammation bother you? So we'll go back to vagal tone in a second, but if we have somebody that's coming off of injury, and I like that sweet spot where they're done with PT, but they're not quite back to 100% and they still need attention. And so people will say, after I run, my knee gets inflamed. Okay, you had a bucket handle repair done on your meniscus. I would expect you to have a little bit of inflammation after a 10-mile run for a while. And if it's there your whole life, does it matter if it goes away in a couple hours? I guess not.
That's a good question.
I think for the practitioners that are listening, when you hear somebody saying this is always inflamed, to use that word unpack, go back and say, how inflamed does it get? Take a picture and show me. Take a measurement and show me. And how long does it last for? Oh, only an hour. Your body did a great job of reabsorbing that again. And was it sore the next day? No. And could you run the next day? Yes. Yay. This is nothing to get too concerned about.
There's a reason for it.
Yeah, it's just like pain, right? Where would we be in a world without, we need pain to tell us things.
Yeah.
When it's out of control, that we have to manage things.
And sometimes people use the word I'm inflamed when what they mean is I hurt.
Correct. Or
And
something irritating.
I hurt in our world is sometimes 124.
Yes, our new
Which
repair and heal.
repair and heal. There's a strain in the tendon that goes to that joint, and that makes the muscle sore.
Yeah.
Muscle's not inflamed, it's tight
Yes.
because the tendon is injured. Let's repair the tendon. And let's repair the tendon and see what happens to your comfort.
Yeah. Do we have questions already?
Yeah, whoever TM is.
Okay.
That's so amazing. Exactly what is going on about turning up the vagus nerve, but it is an amazing thing to watch. That's the truth. I would have been afraid if it was not from so much study with you and FSM about the vagus nerve. That must be why FSM works. I ran all the programs on our new custom care, but it didn't feel like knitting a sweater. It was a scary experience, but after his throat was quivering. That's the other thing is that this is Teresa from Vienna. Had a patient yesterday whose voice was high pitched and tight. Her vocal cords were tight. And they told her that it was from reflux. And she also had a bit of gastroparesis and leaky gut and tons of allergies, like food allergies, environmental allergies, all sorts of things. And I treated, so she said, I have dysphonia. And as I treated her vagus, and she coordinated it with the 2 times she had COVID and the 2 times she had vaccines, and GERD. And as I treated her, and then GERD actually does, the acid fumes injure the vocal cords. So as I treated her vagus, treated scarring in the vagus, she fell asleep. And then treated fibrosis and inflammation in the vocal cords.
Mm-hmm.
And her voice dropped a register like a third for the musicians in the group. And she said she didn't have to strain to talk. The vagus is also connected to the diaphragm. There's a nucleus in the spinal cord, vagal nucleus from the pharynx to the nuclei in the spinal cord for C3, 4, and 5 that operate the diaphragm. And they all work together. So in order to talk, the vagus has to work, and those 3 nerves have to work to push the diaphragm up, to push the air out so you can talk. And at the end of 30 minutes, her voice was noticeably different. I had to ask her husband, I'm not hallucinating this, right? She sounds different. He said, oh yeah. Okay.
That's amazing. So one of the other amazing moments I had is the day I realized that the cerebellum and the diaphragm are the same frequency.
What's up with that?
It's my like core belief that breath and balance are always synergistic.
Oh,
The fact that the frequency gods have also put that together just validates me so much.
see, I just pretended that 84 was not the frequency for the diaphragm because it didn't make any sense to me, but okay.
All the sense in the world that breath and balance is synergistic.
Hmm. That makes sense. And explaining to somebody that the cerebellum is a tyrant, it is a dictator. It does not notify, doesn't tell you why it's doing what it's doing.
Yeah.
It has no need to explain, and it also does not negotiate.
Yeah.
You can do whatever you want. You can stretch forever. You can dig forever. And I will not relax the psoas until you release the ureter from the front of the psoas. It's
Yeah.
just, it's not negotiable. So for 30 years, she's been stretching the psoas, and her pelvis has been cattywampus, and she had a history of bladder infections from the age of 3 until she was 20, on and off. So we did scarring in the ureter. Her back pain went away. Her pelvis worked completely differently. And then she had asthma too. So we worked from the QLs to the diaphragm to the intercostals, which I think might sound familiar to you.
This does sound like a familiar treatment.
Until you can do it, there's no reason you would think of them as being connected.
No, but that is where you have to follow what you feel and follow what changes. I think at one of the advanced, it was like the tagline was like follow the spark. And I always think about that too, is just this spark that's going through someone's body. And it is that flexibility of mind, as you put it, to be able to have a starting point that's based on your skills and your assessment and follow it to where it takes you and to question, okay, what is beside this? And how did it get into this state? What could have happened before? And using your assessment with their story is what helps expedite that process. And sometimes you take a crazy turn that you wouldn't expect. Like,
Yeah. What are the muscles trying to protect?
yes,
The body has a logic.
yes,
It's the fact that sometimes the body's logic makes things worse. We're
yeah,
tightening the muscles because the facets are irritated. The fact that tightening the muscles compresses the facets and the discs more.
yeah,
Yes, it protects them, but it also makes them worse.
yeah,
I'm really sorry. It's cost of doing business.
yeah,
And when you have the ability to treat the cause, at least that's what I think we're doing. That's the frequencies we use. Inflammation in the cartilage and inflammation in the joint capsule and the periosteum. And all of a sudden the muscles over the C1, 2, C2, 3, and C3, 4 facets just get soft.
yeah. And again, this kind of goes back to my core hope for people that I get to work with is to create a safe environment that allows movement to occur. That is my hope and my wish and my prayer for every single person that I work with. And that means bigger things or smaller things to certain people. But that safe environment isn't the pretty room and the smile on your face. It's creating an atmosphere, a condition for the body to give you the information to say, what is tight? Why is this protecting? Why is, in the muscle world, we'll call it splinting? Why is this muscle splinting? What is offline or what is inhibited? And then using that information and then thinking to yourself, okay, if this muscle went back online, what would that create and what would that cause? Because it's not going down to your panel box and just putting on a breaker and then everything just pops up and the lights are on and everybody goes on their merry way. No, there's so much that it gets affected with that.
And that's why The FSM sports became FSM Rehab. So in November, we have a 2-day practicum for people who've taken the core online. And we actually do as many, I think, online courses as we do in-person courses. So the 2-day practicum, and then we've got the 2-day rehab afterwards because, okay, we bring the muscles back online. They're now relaxed, but they're weak. They're not coordinated. They're not entirely sure where they are in space. Now what do we do? And for me, I do the big download dump in the core, but that's what the rehab course is. It's so essential. So for people that are listening, think about spending, it's Monday and Tuesday, isn't it? Monday and Tuesday in November with you, and it's walking, taking a plate out of the cupboard, taking a quart of milk out of the refrigerator, putting a pot of water on the stove. That is a sport.
Yes.
That is your life.
Yeah.
And so that's why we changed the name, because not everybody treats athletes, but somebody that's doing their dishes at night, fixing dinner and vacuuming and the floor and making the bed, that is their sport.
And it is time that we did change the name. I know Kevin was really brilliant a couple of years ago by saying, like, life is a sport. And it's true, but I get it. A lot of people don't consider themselves as athletes, or they don't see a quote unquote athletic population. But getting in and out of your car is an activity that you need patterning or repatterning to help you with, because what we do in the clinic is so profound and it is so fast. We can never expect somebody to, or their nervous system to catch up with that. I am very grateful that we'll be changing the name to Rehab. And
And
we'll
we can,
sports course for the sports advanced is going to be still all sporty and fun. So I get to geek out still, but yeah, it's been a great journey putting it together. And I think it's the story after the story. So you get all this, we talk about all the miracles that happen in the clinic. And I still feel bad about this when John Sharkey came and he had somebody up on stage that had very limited shoulder abduction, and he did some stuff and corrections, and she got her arm up over her head, and everyone like clapping like he was a rock star. And then we went out for lunch after, and he's got his group of 40 people with him, and he says, Kim, you never said much about what we did with her shoulder. And I said, let's see how it is tomorrow, otherwise it's just a party trick. And everybody was like, and I'm like,
spot on.
I didn't mean disrespect, because I have done that in the clinic too, where I've stuck my thumb so far up into somebody's subscap and got their arm up, but the next day they're right back to where they started. That to me is not a success. The success is the week later, the month later, 6 months later that said, hey, we fixed it and it stayed gone. And that's the sports rehab course, is how we can close the case.
And to think of the shoulder as a region, for example, because of the lats, when you change the shoulder, you change the low back and the pelvis.
Yes.
And then you go through the anatomy. And then when you see it in the clinic, so I treated the patient's shoulder, and then the next week he came in and his right hip was bothering him.
Yeah.
Well, because his lat now moves and his hip has to do something different.
Yeah.
Oh, everything is connected to everything.
I had this moment personally a couple days ago. Anybody who's following me on Instagram knows I'm posting daily as I'm getting ready for my next half marathon race. So I thought it would be good to post every day to see all the stuff that goes into training for a race, because we live in this kind of glamorous Insta society where we just see the snapshots of the beautiful kitchen and the beautiful dinner, and not like the meltdown that happened at Safeway because you forgot the onions. So I want to show people the meltdown about the onions. So I've been running and everything, and the other day my upper cervicals were out. I felt it, they were out. It's probably because all the computer stuff I'm doing. I have this eye strain. And then yesterday, so I'm feeling all this upper cervical on my right. And then yesterday I finished my run and my posterior tib was on fire on my left leg. And I'm like, oh, of course, because my neck was sore. And one of the people in the clinic was like, how did you just put that to your left lower leg is messed up because your upper right cervicals? I'm like, well, yeah, because it's just all connected.
Diagonal line.
Again, it's not just it biomechanical levers, everything is connected to everything, and we make things very complicated. But if you can at least have the starting point of everything is connected to everything, I think we've done a decent job of instructing people. I
Yeah.
don't know.
As long as you don't get attached to your starting point.
Exactly. And that's where that flexibility of mind comes in. And that's hard for us type A planners because I've now gotten into the habit of looking at who I'm seeing the day before and planning out their exercises, or I formulate an idea of what I want to do. And I've realized it's just a total waste of time because you have no idea. You may think you know what's going to walk into your clinic and you've seen this person 3 times a week for the last 6 weeks, but you just have to be flexible with, I never say back steps. And I hate when people are like, oh, I took a giant step backwards. No, it's never a backward step. Maybe a lateral step. Maybe the step up was a bit smaller than you thought.
How about thinking about it as a response? It's you do this and that happens, and the response tells you something. It's not a backstep. It's not even a side effect. It's information.
Yes.
Because this caused that, but why did it cause that? And at least that's how my brain works.
No, and I will credit all of the FSM training for thinking why. And it's philosophy that spans across every profession, whether it's dentistry, learning from Mary Ellen Chalmers about, I'll never forget, like thinking, why would I go listen to a dentist talk? But whatever. I don't feel like going to my room and might as well just go. And just being mind blown when she was talking about mouth inflammation and how it robs energy from fighting other sources of infection or inflammation, and everything is connected to everything.
And the trigeminal nerve and how the teeth, the one that blew me away is that the ligaments in the teeth, when you chew, affect the hippocampus and memory. They have data that says people that have dentures end up with memory problems. And the connection is the ligaments in the teeth have an effect on the midbrain and the hippocampus and that particular part of memory and memory processing. And so it adds a question that you ask a patient who presents with early cognitive decline. And I mean, we're looking at leaky gut, we're looking at brain inflammation, we're looking at the vagus. In my life, I would never have thought to ask the patient, do you have dentures?
No, at least not for that. Maybe you're thinking of, I don't even know actually why I would ask.
I would, without that little factoid. Okay, who knew?
Who knew?
Yeah, we have such an incredible resource group in the FSM community because FSM is a tool that so many professions can use.
I am so grateful all the time when I stumble across something that I have no idea what it is, or of course you can Google it, but the fact that I have this resource bank that I can email or text people and who are brilliant in their field, who I feel so grateful that they respond not even within that day, but typically within a few seconds.
Mm-hmm.
It's a family that we have in our world that I am so grateful for. So if there's some imaging that I don't understand, I can talk to you. If there's some sort of drug or side effect, we've got the Dr. Burks and Catholis on speed dial.
Exactly.
Dr. Sosnowski, like I am eternally grateful for their help, because yes, maybe I can't prescribe something or maybe I can't treat something, but at least it's giving me this insight to, okay, if this is affected, then that's affected. If that's affected, this is going to be affected. And it helps put together that comprehensive picture that going back to the beginning of what we're talking about, I think is really missing in our medical model right now.
Yeah, we're just really lucky with the community that has evolved in the FSM world.
Yes.
It's everything from massage therapists to PM&R to athletic trainers to naturopaths to dentists to what I don't know any other technique that has that many medical or clinical applications.
Right.
So we have a cranial osteopath that's going to educate us on what the Dura does to make your brain work better as long as you've got the Dura stretchy and doing what it's supposed to do. Excuse me? And
Yes,
then Patrick Wood is a neuropsychopharmacologist. He's an MD. And we had a practitioner who ran 40 and 89 for 3 hours one day, and it felt so good. She did it for a second day for 3 hours. Then she did it for a third day for 3 hours. Then she ran it for 18 hours. She ran it 3 hours a day for 6 days. At the end of 6 days, she had full body pain, brain fog, cognitive decline, couldn't think straight. She was a mess. And I had no idea why. And Dr. Wood said, "Oh, this is why." I said, "Would you mind doing an hour on what the midbrain actually does?" And almost always 40 and 89 for 30 minutes makes everybody's world better.
Yeah.
I would never in my wildest dreams have imagined what would happen if you ran 40 and 89 for 18 hours. Why would
Yeah.
anybody do that? It felt so good, I just did it again. And then the wheels came off. Until you have a tool that lets you manipulate it directly, you don't have a way to know what your limits are. So I'm hoping that Dr. Wood can still, he's going to come. I have to have room for everybody. So now the people that thought they were doing 90-minute lectures are now doing 60-minute lectures because I have 2 additional speakers.
Yeah, it's like watching a Tetris game of just moving the blocks and the people. And I'm glad you don't have 2 separate tracks anymore, because we're really not 2 separate tracks anymore. Everything is connected to everything and everybody is connected to everybody. So we have to see everybody's stuff.
Physical medicine is neurology. Physical medicine is the gut.
Yeah.
GI medicine has to do, is there any way to fix the gut without getting the psoas and the quadratus lumborum to work right so you breathe right so the vagus isn't glued to the gut?
It's bringing just a whole new appreciation to how connected everything is. And it's hard, especially when we're really myopically trained. We can't add a day or 2 to the advanced lead, because then we'd be in Phoenix for a month.
Yeah, and it's like the core actually needs to be 6 days and I can't do it. I refuse to be the guy that makes you take 2 or 3-day modules before you are competent and I just won't do that. No. I'll overwhelm you. And then you go home and study on your own and let FSM responses teach you what you need to know.
Yeah.
Because that's how you really learn, is go swim.
Yeah. Your floaties and you'll be
Your floaties.
just fine.
Start with this. This
Yeah.
is the easy stuff. And then you'll learn.
Right.
Yeah.
And you have us every Wednesday.
It's so much fun.
We're almost out of time, actually.
We did that again. Oh, wait a minute. We have Louise. Thank you, Louise. To your faithful followers, thank you. Endless strand of pearls on and on. These 1 hour Wednesdays you're such inspiring, full of wow moments. Oh, you're welcome. Wednesday freebies, pearls. Okay, next week we have to wear pearls. Do you have pearls? I can send you some. Okay, good. We'll wear pearls next week. Thank you, Louise. Chewing on a specific food, we get flashbacks of our childhood while chewing on the food. Oh, I disliked it when we had to make a choice between 2 rooms. Oh yeah, that's a thing.
I wanted to talk quickly about the chewing thing, but Jen, I don't know if you had a chance to watch my interviews with Dr. Mesnick and Sosnowski. They're so much fun.
Yes.
Jen was going to talk about some autoimmune and autism and some other things. And it was just sleep apnea the whole time because it's just so important. And she was talking about the jaw. And one of the causes of an increased amount of sleep apnea is palate changes due to these underdeveloped jaw muscles because we're not chewing hard enough food anymore. So she was bringing up data, and she really made a lot of sense, right? We're smoothies and yogurts and we overcook our vegetables. We're not chewing on hard, raw vegetables and tough meat and all the things that we were designed to do.
Wow.
Yeah, I know.
And that just took me back to Mary Ellen and the ligaments.
Yeah.
And the brain.
Yes. So when you were saying that, that's what I went back to Jen's whole part.
Wow.
Yeah.
So that means I have to find an hour someplace to put Jen Sosnowski?
You might.
Okay. All right.
Well,
The advanced is going to be fun.
You look at your little map, your schematic of March.
The nice thing is that this year we have basically 4 days because we have 2 days of the advanced and 2 days of the symposium.
Yeah.
And I need case reports, you guys, because we learn from each other. One of the things I did yesterday was treating somebody who said she had very dense breasts. And we have a published paper on that.
Yeah.
I can do that. So you treat fibrosis and oxalates and scar tissue in the mammary glands.
Mammary glands.
And her breast tissue completely changed, like completely. And I said, you have to feel this because is it doing what? She said, how, what? And the nice thing is it'll stay that way, but we learn from each other because I teach what I know, but we have thousands of practitioners.
Yeah.
And each practitioner has experiences and treats patients and types of patients that I will never see.
Yeah.
And so the case reports are the most important part of the symposium. It's wonderful to have Juliana Mortensen and it's wonderful to have Jim Oshman, and that's all good.
Yeah.
But the case reports are, to me, the most important part of the symposium, and there's no place to put them in the advanced. So there will be an email coming out soon on a regular basis. I'm looking over at Kevin to remind everybody that it's 20 slides. You can do that.
Yeah.
You can do that. And what you take for granted, I just did this and this.
I think that's a big part, what you take for granted, because we all want to hear. And if anything, maybe it's not anything new, but it validates, yes, okay, I have been doing that. I am on the right track. I got alarms going. It's 4:02.
It's 4 o'clock already? Wow.
I may or may not be here next week. I may be away, but I will let you know and I will do my best.
Next week.
What?
We're not here next week.
Oh, we're not here next week because we are doing a core next week, Wednesday to Sunday. We've got 18, 20, something like that.
Yeah, 16 or 17, I think.
Yeah, it's 16,
Great.
17. It's nice, manageable class.
Yes, that's great.
Yeah. Oh, and by the way, anybody that's thinking about signing up for December, one of the table side assistants is going to be Dave Burke. I'm just saying.
So you're going to want to be there.
Just saying.
And come visit us in Troutdale in November. So go take 2 days with Dr. Carol and then come hang out for 2 days with me, and it'll be
Oh,
that facility is just beautiful. You want to be there. So
yeah.
if you're on the fence, this is the time to come.
And the FSM rehab really is an essential sort of follow-up to the core. It's one thing to know how to make the neck go smushy and the shoulder go smushy and the low back and the viscera go smushy, but that's a start. That relaxes the muscles that were tight, but they're weak and uncoordinated.
Yeah.
And I don't have time to tell you how to get them coordinated and stronger and what exercises to do and where to start. More about that than I will ever know. So the rehab part is the natural follow-up, and it gives you a basis in knowledge about how to get the patient from better to better.
Yes. And on that, it's time to go.
It's time to go.
So we won't see you guys next week. We will be back the week after.
2
And
weeks.
then, yes. And then
Okay.
when we're together in Troutdale, we can do it together live.
It'll be so much fun.
Yay. All right, everybody. We'll see you in 2 weeks.
See you in 2 weeks. Do good things.
The Frequency Specific Microcurrent podcast has been produced by Frequency Specific Seminars for entertainment, educational, and information purposes only. The information and opinion provided in the podcast are not medical advice, do not create any type of doctor-patient relationship, and unless expressly stated, do not reflect the opinions of its affiliates, subsidiaries, or sponsors, or the hosts or any of the podcast guests or affiliated professional organizations. No person should act or refrain from acting on the basis of the content provided in any podcast without first seeking appropriate medical advice and counseling. No information provided in any podcast should be used as a substitute for personalized medical advice and counseling. FSS expressly disclaims any and all liability relating to any actions taken or not taken based on or any contents of this podcast.